Welcome to the conference session titled Transfusion-Associated Iron Overload. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do respectfully ask that you do two things to help us manage the incoming questions. Submit your entire question all at the same time, and please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Shortly after speaking, we'll open up a short poll for some questions from the audience to respond to in real time using the polling feature in the right-hand engagement panel of the session. Please just click on the survey icon to participate if you wish. Today's specialist is Dr. Elizabeth Bohe-Carnes, who is a Texas native and passionate about serving people of her home community. She earned her Bachelor's of Science degree in biochemistry from the University of Texas at Austin, followed by work with the MD Anderson Cancer Center Umbilical Cord Blood Bank in Houston. She received her medical degree from UT Health San Antonio and completed her residency in internal medicine and fellowship in hematology and medical oncology at UT Health Science Center. She joined UT Health San Antonio MD Anderson Cancer Center in 2016 as a director of the Adult Non-Malignant Hematology Program and co-director of the Adolescent Young Adult Oncology Program. Her clinical interests include cancers of the blood, non-malignant disorders of the blood, and cancer of the soft tissue or bone. With that said, it is my pleasure to welcome Dr. Elizabeth Bohe-Carnes.
Hello. Hi. Good morning, everybody, or afternoon, depending on what time zone everybody is joining us. I'm so excited to be here, and I'm excited to be talking about benign or non-malignant hematology, though I'm sure everybody in this conference knows that non-malignant disorders related to blood are not necessarily benign, meaning not serious. So there's lots of things to go over. So my preferred terminology that I like to use is I'm an expert in classical hematology, which usually means non-malignant disorders. But today I'm going to be talking to you about one particular topic, specifically transfusion-associated iron overload. I'm going to explain exactly what that means as we go forward. And again, I'm excited to be here with you today. So let's see. First, I wanted to make sure I go over some disclosure of financial interests. So intermittently, a couple times a year, I'm a paid speaker for two pharmaceutical companies, Gilead and Rigel, though I am not going to be talking about any drugs or anything related to any products from these pharmaceutical companies. So there's no financial disclosures for any medicine I'm talking about today. So what are we going to talk about? So this is the introductory slide. So first, I'm going to be talking about discussing the meaning of transfusional iron overload. What does that mean? We're going to be talking about discussing complications of iron overload and discuss treatments that we use for this particular disorder. So let's go a little bit into some basic pathophysiology of why is iron important? Why do we need it? So what is iron function in the human body? So iron is an essential component of a molecule called hemoglobin. The picture on this slide is the molecular structure of hemoglobin. So hemoglobin is made of 4 different heme chains. So there's 2 beta and 2 alpha. Each one of those heme chains has an iron molecule in the center. So in this particular diagram that's shown, the iron is represented by the yellow and blue discs. So you can see for each one functional molecule of hemoglobin, you need 4 iron molecules to make it up. If you do not have iron, then you cannot make a functional hemoglobin. So what does hemoglobin do? So hemoglobin is located in our red blood cells, and it binds to oxygen in our body. So the hemoglobin travels through the bloodstream, first through the lungs, then oxygen gets loaded on to this molecule, and then it's transported to the part of the body that needs to use the oxygen. So hemoglobin functions inside red blood cells, and it functions to carry oxygen from lungs to other parts of the body. So if you do not have enough iron, then you do not make enough hemoglobin, you do not make enough red blood cells, and that leads to severe anemia, and then you cannot get enough oxygen to your tissues. It is a problem if we do not have enough iron, so we're low, but then also it's a problem if we have too much iron. So these are 2 different pictures on the screen. The one on the left, that's a little bit more light pink, is what the blood looks like under the microscope, called a peripheral blood smear, when someone does not have enough iron. So it very commonly in clinic, all hematologists will have a microscope in our office where we see patients. And if you have a strong connection with your doctor, then you could even ask to look at your blood under the microscope sometimes if it's located in a safe area in the clinic setting. And you could see that on the left-hand side, the circles, or the red blood cells, have a lot of white on the inside. So that's what we call central pallor, and there's not enough iron involved. The slide that's on the right is an example of what the red cells look like when there is either too much iron or a normal amount of iron. And the red blood cells look nice and fully pink all the way close to the middle. So how much iron are we supposed to have? So we don't want too much and we don't want too little. We want the exact right amount. So the normal amount of iron that's supposed to be in the body is between 3,000 and 4,000 milligrams total. So where is the iron found? So the majority of that, 2,500 of the total amount, is usually in the circulating red blood cells. We do have iron in other parts of our body, so a smaller amount, about 400 milligrams, is found in some other important proteins, things called myoglobin or some other enzymes that need iron. A very, very tiny amount of iron is bound to a carrier protein called transferrin. And then we have a storage iron. So our body does have a way of storing away extra iron for usage when we need it. And that storage iron is stored in a form that we call ferritin, or also hemosiderin. So in adult men, they usually have about 1,000 milligrams of storage iron in their body. This is primarily found within the liver, the spleen, and the bone marrow. Women on average tend to have less, about 500 milligrams of stored iron, though this is variable based on menstruation status, how many pregnancies they've had, and how much intake. So there's just more variability in women due to pregnancies, which uses a lot of iron. So to make a baby inside the body, it uses a very significant amount of a woman's iron. And then also with monthly menstruation, you lose iron intermittently that way. postmenopausal women should have the same amount of storage iron as men. So how do we get iron into our body? So when everything's working the way it's supposed to, we get iron from the food we eat. So in the form of nutritional iron. So I like this slide, and I think it's interesting because there are little misconceptions on which foods are actually the highest in iron compared to others. So the Western diet usually consists of about 10 to 20 milligrams of iron per day. And these numbers that are listed in this slide explains how much iron is in 100 grams of a particular serving. So I'll explain that a little bit. So one of the foods that has the highest amount of iron is chicken livers. Now, they can be cooked, it's okay. But for weight by weight compared to red meat or beef steaks, there's actually not all that much iron in steak from what people usually think of. Now, 100 milligram portion is about 4 ounces. So it depends on the actual portion of the steak you're eating. If you're eating a 10 ounce, big fillet, you can get more iron that way. But both chicken liver and that is actually the highest. Chicken itself, again, weight by weight, actually about 4 ounces of meat actually has a slightly more amount of iron than red meat and steak. Our body absorbs iron from meat products a little bit better than non-heme iron from vegetable sources, but there's still many sources of vegetables that are very high in iron. So the highest is usually spinach. That 9 milligrams would be a full bunch of spinach. And of course, if you have ever cooked down a bunch of spinach, that's actually a very small portion. So it depends if you're eating raw or cooked, but both have high amounts of iron. And so also very high is beans, so kidney beans, and then brown rice actually has a decent amount of iron as well. So what we're talking about today, though, are people who have too much iron in their system because they've had red blood cell transfusions. So I went over how much iron is in different nutritional products. So if you eat a steak, you're getting 1 milligram of iron, but for each 1 unit of red blood cells that's given to somebody in their body, that's 250 milligrams of iron. So after we receive about 15 units on the average adult size, then someone starts to get in the elevated too high iron level. We use the term a transfusional iron overload as the medical diagnosis for people who have too much iron in their body because of getting repeat blood transfusions. Now, total body weight does matter. So in children, they can start to get iron overloaded even as little as between 7 and 10 units of red blood cells throughout their life that they've received. And of course, if someone is a very petite person, then you can get transfusional iron overload. But this would be an average about 70 kilogram adult man or woman. We say you get iron overloaded after about 15 total units in your life. So why is it a problem? Because I went over a little bit why we need iron. If we have too little iron, we become anemic and we can't make hemoglobin and people get sick that way. But what happens if we have too much? So one of the first things that happens is our body stores away that extra iron. Our body does not have a way of excreting that extra iron in our urine or our stool or enzymatic breakdown. So the more we get, the more we tend to keep. And the body says, oh gosh, I have to find more places to store this iron. And the first place is the liver. So these are MRI pictures, which is one test that we use to measure how much iron is in someone's body. And since iron is a metal and an MRI uses magnets, it looks different. The magnetic fields that creates different pictures from an MRI machine, and we can easily see what tissues have too much iron in it or not enough iron. So just to show you the difference, this picture would be a picture of a patient who has too much iron. It looks black on an MRI on the A, and B would be a picture of an MRI in a patient after they've undergone treatment to get rid of the excess iron. And so you can actually see the really big difference on these pictures, how we can measure it from the MRI of what it looks like. And so if you have too much iron in the liver, it then leads to liver damage and scarring of the liver, increase in our liver function tests that we measure from the blood, but then ultimately in very severe cases, it leads to liver failure and leading to have a liver transplant in very, very severe cases. So we want to make sure we treat it before it gets to that point. It does take a long time for the iron to build up to that level. This is not something that you're going to suddenly get after getting 15 units of red cells, go into liver failure. It's a gradual process, but you want to make sure it's looked at and treated before it builds up to the point where it actually is creating true organ function problems. So after the body fills up the liver, then it starts looking for other places to store the extra iron. So the other place that can be stored is in the heart. So these are biopsies, or meaning very small needle tissue pieces of cells in our body. And then we can stain and look at how much iron. So the A is actually a picture of a biopsy of a heart muscle, and the blue is the iron that's stored within the heart muscle. Your heart muscle should not have that much iron in the tissues. And this particular patient, we can see that it has iron scattered throughout the heart muscle. B would be a liver biopsy, and what that looks like in the same patient once they already have too much iron. So the body stores extra away, and it's finding all these tissues and places to put it because it has too much. What are some other things that can happen? So we worry the most about liver or heart problems, but the body can also store iron in the pancreas. If the pancreas is not working, then we have problems related to insulin, so that can lead to diabetes. It can also have problems with our gonads, so ovaries, testicles, which leads to low testosterone levels, low hormone levels, decreased libido, problems having erections, sexual function. It can also, the extra iron can be stored in the skin, and this is called bronze diabetes sometimes, where you could see this is a picture of a patient who has problems with iron overload that's very severe. So his body has stored away the extra iron. He looks very tan, but he's not tan because of sun exposure. It's the actual iron molecules getting deposited in the skin. You can see from this picture that his eyes look yellow, and that is because he's also in liver failure, and there's a buildup of a molecule called bilirubin. So this would be an extreme case of a picture of a patient who has the end-stage problems of iron overload. And then lastly, we can deposit the iron within our joints. Most often that happens in the knuckle area, and then this joint right here. So people feel like they have arthritis first in their hands, and then in extreme cases in other joints. Now, this would not necessarily manifest as first having knee pain or hip pain. Lots of people have arthritis for a lot of other reasons, but it does get deposited in joints. Okay, so I went over a little bit about why we need iron and why it's important to not have too much and not have too little. So people who get blood transfusions run into a problem with getting too much. And I hope I didn't scare anybody on all the different things that can happen in severe situations if we let the iron build up. But the good news is we have treatments available to prevent the iron from building up. Many people need the blood transfusions to survive. If you didn't get them, you would die. And so they say, gosh, this is a catch-22. I need the extra blood in order to be okay, but you're telling me it's dangerous with too much iron. That's true, but we have treatments to help our body get rid of the extra iron. So I'm going to go over what those are. So one option for some patients is phlebotomy. So that's where if they're not anemic and their body is making enough red blood cells, then we can actually just remove blood as if they were donating blood to someone else. And then over time, that will remove some of the excess iron. But in many cases, that's not possible because someone needs the blood transfusions given to them. So you can't imagine taking blood away. That would be counterbalancing the treatment plan. And so we have medicines that are called iron chelators. The word chelator is a medicine or a molecule that will bind to some sort of usually a metal. So there's aluminum chelators, and the ones that I'm going to be talking about specifically are iron. So these are medicines that are taken in different forms. They bind to the extra iron, and then they help our body get rid of the extra iron. So when do we start even talking about these medicines? So typically in an adult, treatment starts after a patient has received between 10 to 20 units of red blood cells throughout their lifetime of transfusions. Again, I mentioned earlier that does depend on the weight and how spaced out the blood transfusions are within a course of a patient's treatment, but there's ways that we can actually measure how much iron is in the blood with some basic blood tests. So we usually start these discussions about which medicine for an iron chelator is most appropriate when the ferritin is over 1,000. Now, ferritin is a very good marker for how much iron we have, but the ferritin lab, which is collected just from a regular simple blood test that they do from the vein, so a venous puncture in the doctor's office, sometimes the ferritin can be high for reasons that don't have anything to do with iron. So then we actually measure something called an iron saturation from the blood, or some cases need that actual liver MRI to measure how much iron is built up in the body. It depends on each individual case. So if we're using ferritin and we believe that's the best marker to measure how much iron is in someone's body, then once the ferritin's over 1,000, we think that's too much. And so we need to start one of these medicines. And then we treat with the medicines until the ferritin decreases less than somewhere between 200 and 300. And then we can stop the medicines for a while. Some people, if they're continuing to receive red blood cell transfusions, then they might have to continue to receive the iron chelating medicines. So it also, how much you're putting in depends on how much you need to take out. So it's not a one size fits all. It has to be personalized for each patient. So let me start talking about some of the different medicines that are available. So there's 4 commercially available medicines that can be used to decrease iron in someone's body. And then there's some experimental treatments. So the first one I want to talk about is called Deferoxamine, or then the trade name is Desferal. As you all know, every medicine has 2 names, so a generic name and then a trade name. And so that's the same thing if we're talking about Deferoxamine or the trade name Desferal. So this medicine has been around the longest. It is given in 2 forms, either through the IV as an IV infusion, usually over a good number of hours. An IV infusion somewhere between 4 and 8 hours, depending on what dose we have to give people. The other option is it's given as a under the skin subcutaneous infusion, usually overnight. So this is quite complicated. This is not the most commonly prescribed way. This is what's used most in children still. And this is a picture of a patient of what it looks like to have a subcutaneous medication infusion pump. So the needle is very small. It's a little butterfly needle that has a circle on it so it can't really get dislodged. It goes right under the skin. This is not the same as putting an IV line. It doesn't hurt that much. And then it's taped over just to make sure it doesn't get pulled out when someone's sleeping. And then there's a pump that delivers the medicine slowly through the night while they're sleeping. And so again, it's two forms, either IV in the doctor's office, but over in numerous hours, or the overnight subcutaneous infusion pump. The bad side effect that can happen with Desferal is it is related to long-term hearing loss. So patients who are on this intermittently get the hearing checked to make sure it's not causing problems. And it doesn't require that much lab monitoring. Your labs are usually checked much more often than every 3 months for other medical reasons, but we make sure we look at the iron labs to see how it's working. This is the safest for patients who already have liver or kidney problems, specifically kidney problems. And so the other medicines I'm going to talk about that are much easier to give can actually hurt the kidneys. So this is what we tend to use again for children or patients who have kidney problems. So what's the next medicine? So it's called Deferiprone, or the trade name is Ferriprox. So this is different. It's an oral medicine. So these are pills or tablets. Actually, they come in a capsule that are taken every day. It does come in a liquid form as well if someone has a peg tube or is unable to swallow capsules. They're very small, so that's helpful. The dosing is usually 3 times a day, though last year in 2020, the company came out with a different dosing regimen where it can be taken twice a day. So once in the morning, once at night. It does need to be monitored with labs monthly to make sure it's not hurting the liver or the kidneys. A side effect that's interesting is it doesn't bind just to iron, it binds to zinc. So your doctor will be monitoring to make sure you don't need a zinc tablet or a zinc supplement in addition to getting rid of the iron. Some less common side effects, but possible, is people can feel a little bit nauseated or queasy, and very rarely, this particular medicine can cause a problem where it decreases the immune system. It is really important to know that actually this is only FDA approved for patients that have transfusional iron overload related to sickle cell disease or thalassemia. It's not approved for patients who have transfusional iron overload related to aplastic anemia, MDS, or leukemia. But if your doctor thinks that this is appropriate, sometimes they'll be talking about off-label usage for particular indications if it's a good fit for you. So the next medicine that is approved for all different types of transfusional iron overload is called Deferisarox, or it has 2 forms. It's made by the same company. One of the names is Jadenu, or the other is Exjade. So these are fundamentally the same medicine, it just comes in a little bit different forms, so it goes based on a different name. So again, this is FDA approved for patients who have transfusional iron overload related to aplastic anemia, MDS, cancer, leukemia, things like that. It's an oral medicine, so it comes as either tablets that are swallowed. The dose is once a day, but for the average adult dose, the dose is usually 4 pills taken at the same time once a day. That exact dose of how many pills someone takes depends on how much iron they have and also their body weight. It also comes in sprinkles. That's what this picture is showing. It's these, what looks like a little sugar substitute, I guess, little packets that then the medicine is sprinkled into usually applesauce or yogurt. So this is very commonly used for children, and but can also be used for people who have problems swallowing tablets. For adults, you just don't want to take as many pills and you want to mix the medicine up with a small amount of applesauce in the morning. That's perfectly fine. So it's available in that form. I didn't mention on this slide, but Exjade comes in these tablets that are dissolved in a glass of water, taken once a day and then swallowed that way. Exjade isn't used quite as often anymore. Most people do prefer just to swallow a tablet, though again, there's reasons why people wouldn't be able to do that. And so there's the sprinkles or the tablet that gets dissolved in a glass of water once a day. This does also require labs to be checked once a month to make sure it's not causing any liver or kidney problems. It can cause some mild nausea. It's important. It cannot be used in patients who have severe kidney problems. It can be used in patients who have a little bit of mild, what we call renal insufficiency. But if someone has severe renal insufficiency or dialysis, then we try to stay away from ones that can harm the kidneys further. So lastly, I am a principal investigator and running a research trial for a experimental medicine that could be added to this list eventually, we hope, if it shows to be safe and effective. So I'm running a clinical trial for a compound that doesn't yet have a name. So it's called SP420. So it doesn't have a fancy, catchy drug company name yet. It's sponsored by Pharmaceuticals. This particular medicine is oral tablets that will be taken 3 times a week, so Monday, Wednesday, Friday, to decrease iron overload. In animal experiments, it was shown to be completely safe in the kidneys, but we're running the clinical trials in humans and people who have transfusional iron overload to make sure that it's appropriate and is as safe as we believe it to be. So if you're in the San Antonio area and wanted to talk to me about enrolling into this clinical trial, I'm happy to talk to you about it. So this is my information. Again, my name's Elizabeth Bohe Carnes. I'm in San Antonio, Texas, work for UT Health San Antonio in the hematology clinics at the Mays Cancer Center. And I put my work email on there, and I'm happy to correspond with people by email if you like. So I am ready for questions. I hope that was informative.
Thank you so much, Dr. Bohe Carnes, for the wonderful presentations. We do have a few questions for you. Our first question comes from an 81-year-old female that has been diagnosed with MDS, RARS. Ferritin level has been as high as 1800, but it's also been as low as 980 for the 4+ years. At what level is ferritin considered to be too high and needing treatment?
So it is a range. So it's usually when the ferritin is higher than 1000 is when we would say, okay, take a step back, think, does this person need an iron chelation? Yes or no? I think the answer is it depends also how much transfusion they're still getting in their body. And if there more is coming in and the ferritin's higher than 1000, then it's only going to go up with time. So we want to try to get ahead of it before it becomes a problem. Again, in some people, ferritin is not necessarily the best marker of how much iron they have. So the doctors will also look at what's called a iron saturation or transferrin saturation. When that's higher than 50–60%, then that can say, look, you have too much iron. And then if, again, that's on the borderline, then the hematologist can consider doing a one-time MRI of the liver to measure. So to be clear, to answer that question, we say ferritin over 1,000 is an indication for chelation, but it's not a one size fits all. I do have patients who are over 1,000 who I decide not to add on another medicine for due to the fact they're taking so many things. I don't want to hurt their kidneys. There's other consideration. So I think it depends on how much iron they're continuously getting in on what cutoff we should use to start treatment.
Thank you. When should a patient begin testing their ferritin level? Is there a certain number of transfusions that a patient should have in mind that they should be maybe speaking to their physician about testing for their ferritin level if it's not already being done?
Yes, so after 15 units. And that, again, it depends on the body weight. In a very petite person, then they should start checking the iron levels after transfusion of about 10 total units of red blood cells. But usually for an average adult, we should start checking after about 15 total units.
Thank you. This question comes from a patient whose ferritin level is 2,000 and is being transfused every 2 weeks. They are taking Jadenu. How long does it usually take for a patient to see a response to the treatment?
So that's actually a complicated answer. So in a patient who has a ferritin of about 2,000 and they're not getting additional units in, then they would need to stay on the Jadenu probably for about 2 years to get rid of the excess iron. This is a common scenario that they need ongoing red blood cells. So they're already high and they're still getting more. So the answer to that is usually the iron chelation does tend to be ongoing and doesn't stop, though the dosing of the Jadenu is also important. I am guilty of this myself in my practice, actually. We start patients on a relatively low dose of Jadenu, and we should be increasing the dose. The problem is it only comes in one particular size tablet. So in order to convince my patients that, look, we can get more iron off them, but instead of taking 3 pills per day, you're going to have to start taking 5 extra pills per day. Sometimes that's a sell that nobody really wants to take 5 extra pills per day. But I do want people to be aware that they can go on the Jadenu website and there's good information that says once you start at a level, make sure you're getting enough of the medicine to really be effective to get rid of the extra iron. So I think the take home point of that is the more blood that you're getting in, the more iron that you're getting in, usually the more iron you need out. So increase doses of the medicine or treatment for longer.
Thank you. Does it matter the type of blood that you're receiving? Does it have an impact on iron, your developing iron overload?
No, it does not. So, so there's different answers to that, but the answer is no. So when we talk about blood type, sometimes they mean about blood type like A, B, positive or negative. There's other processing of blood, which we call leuko-reduced or irradiated, but it doesn't matter. So a unit of blood contains the same amount of iron for each type.
Thank you. You had mentioned about the possibility of there being side effects such as vision loss. Should patients receive some type of baseline for their organ functions prior to starting medication such as Exjade or Jadenu?
Really just blood work. So yes, your doctor will know your liver and kidney function. For the hearing loss specifically, that's with the IV medicine. So that's none of the oral treatments. For if they're starting the IV Desferal, that's the one that can be associated with hearing loss. Some specialists will say get a baseline level. Personally, if a patient does not have any history at all of hearing loss whatsoever, I don't necessarily need a baseline level. But what's common is people will have some degree of hearing loss already, either tinnitus or needing hearing aids, completely unrelated to the medicine. They already have a problem with that. And this is with the IV Desferal specifically. Those are the patients I will get a baseline for, because you need to know, is the medicine doing it, or do they have hearing loss problems from other reasons? You do not need a hearing test or eye screening for baseline for the oral medications, but blood work, liver and kidney tests, which your doctor will do already, is part of it.
Thank you. If a patient is looking to move from using Desferal to Exjade, what does that process like? How would that occur?
So again, Desferal is the IV medication. I would imagine that the main reason why we keep people on Desferal is because they have some underlying kidney issues, and we do not want to put them on any of the oral medicines that can be hard on the kidneys. So if that's not the case for this particular patient and their kidney function is normal and they're getting the IV medicine maybe just for ordering convenience, I would say, if they get blood and they get the Desferal at the same time and they want to go to an oral medicine, that's a very easy change. I mean, you can just stop the IV and start the oral the next day. There's no transition in between. But I just want to be very clear, the limiting step on the oral medicines, which are much more convenient, is that they're hard on the kidneys. So your doctor may specifically say, look, we want to do the IV, which is not as convenient, but protect the kidneys. That's why we're doing the research study on this newer drug that is oral 3 times a week and hopefully doesn't hurt the kidney. But of course, that's not FDA approved yet.
Well, thank you so much, Dr. Bohe-Carnes, for spending your time with us today and sharing your expertise with all of us. If you would like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking replay or navigating the on tab in the platform hub. If you have any additional questions, you are welcome to send them to us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Please be sure to visit our exhibit hall. The next educational session will start at 1:15 p.m. Eastern Time. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are always here to help you and your family, as we've done for the past 37 years. This concludes our session.